Strong liaison team. Our liaison team works 24 hours, 7 days a week. Doctors on call, nurses, and then if any patient in any department of the hospital have a psychiatric problem, and I mean any department, you just imagine it, any department in the hospital has a psychiatric problem, we'll call the RAID team. And the RAID team will respond to the emergency department within an hour, to assessment unit within 4 hours, to any ward within 24 hours. And then the whole team will be involved with the patient. Medical, psychiatric, social worker, work alongside the other clinicians. Could be surgeons, geriatricians, internal medicine, cardiology, children, whatever, work alongside them. And in Birmingham, just for Dr. Saad, in Birmingham, we see patients from the age of 16 upwards. In Stoke-on-Trent, we see patients from 0 to over 100. So child psychiatry liaison, old age liaison, general liaison, all in one team. So people in the hospital don't need to think, is that child, is that old age, is that general, is that addiction? Whatever the problem is, just send it to us and deal with it. We put training to the staff, our staff and the acute hospital staff, just early intervention. That is the team. So we have two consultants, we have psychologists, we have band 7 nurses, which is like senior nurses, we have band 6 nurses, we have research assistants, we have admin people, and each team is working in the hospital like anything else. Like if you're working in medicine, and then you have a cardiology patient, and non-cardiologists see them, they will come. The reason the psychiatrist will come. This is the referral pathway. As I said, they come, they deal with any referral, sorted it out, discharge them. These are the sort of problems we deal with. So every month in my team alone, we have 5 teams. Every month we see 350 new patients. For you, that's a joke. That's nothing. In the UK, that's a lot. And you see 1/3 of them come for self-harm, 20% depression, alcohol and substance misuse about 13%, psychosis, dementia is about 20%, and anxiety about 6%. This is how we meet the target. We really see the patient NE on average within 20 minutes, though the target is an hour. This is the patient satisfaction. Patients really love it. They think they believe we improved their care, we improved the quality. When we did quantitative analysis, patients were saying how we made the difference for them, listen to them, help to assist with the communication with the medical team. And this is the feedback from the acute hospital staff, the other doctors and other nurses and clinicians. They love the liaison team. They feel them very, very supportive. But England is different. Everything is based on money. You think about patients' quality of care, good, but unless you save money, they will not give you any money. So they gave us £1 million for each team, and I had this assessment I've done this paper and I published it. Having the liaison team working alongside the medical teams, if you have a hospital with 500 beds, we save 66 beds every day. By discharging people early, by putting them in the right pathways, treating their depression, treating their cognitive impairment, sorting out their delirium. So that improves the quality of care a lot. When I published that, the London School of Economics did not believe this, and had one of the scary moments of my life when I had a very senior person calling me at home, basically saying, we don't believe you. And we are going to send the London School of Economics to review all the work we have done. And they asked me whether they would like to come clean before we find me. So the London School of Economics came, reviewed everything, and guess what they said? They loved our model. And they said every £1 spent on the liaison team will return £4, which is better than any business you can think of. And from that moment, as Dr. Samir said, the team, the model, just spread across the UK. And I had people from Australia, I had Yale University doing the same thing and applying it. And I'll love to do that here. We had another independent evaluation. Again, they said, hang on a second, you have done this evaluation. We don't trust you 100%. Part of it could be related to what Muhammad Salah was talking about. We'll talk about that later. But anyway, we did another independent evaluation. Used the same methodology again, but completely independent. And what we found with the liaison team, people who come to the ED frequently, they start coming less. And people who are admitted to the hospital frequently, they get admitted less, and they stay less in the hospital. And when they looked on all the 5 teams, independent from me, they said every pound, if you look at this, every pound is spent on us, we almost return 3 pounds back to the economy. That's very good business. But then they looked into every hospital separately. So the first hospital heft, this is where I work. This is where we have integrated work. Geriatric medicine, with old age psychiatry, with general psychiatry, with addiction psychiatry, all together. Every pound spent will return 5 pounds. But if you look at this hospital, which is a very big hospital called the Elizabeth Hospital, they did only emergency department, and they did only general psychiatry, just self-harm. Every pound spent, they lost £1.07. So by doing the integrated work in Birmingham, we are actually in one hospital paying for the team in another hospital. Right, enough of rate. So that's his rate, that's the liaison. We did something else. Again, I'm sure أساتذتنا أكيد هيفكروا في الحاجات دي ويشوفوا إذا كان ممكن نعمل حاجة زي كده. عملنا حاجة اسمها Psychiatric Decision Unit, PGU, and I published paper about 6 months ago. Our patients come to the emergency department and they feel they are not treated well. The nurses, the doctors are not treating them well. They think they are psych patients, all these kind of things. And when we go to see them in the ED department, the atmosphere is not right. It's quick, accidents, blood, all these kind of things. So we had a little suite, we called it Psychiatric Decision Unit. And we take the patients from the ED to the PGU. How many beds we have in the PGU? Do you want to guess? No beds. It's all recliners, chairs, music, nurses, psychologists, and the maximum stay allowed to the patient in that unit is 24 hours. This is not admission. Just come to our unit and we'll have a better look at you. We'll use the psychiatric interventions. The average length of stay the patient is staying in the PGU is 16 hours. In that time, we bring in the family, we bring in the social worker, we start looking at the patient, work with them. And what we have done, it reduced the need for psychiatric inpatients by 28%. Because when we see a patient at the ED, and the patient shouting and everything is excited, we say, okay, we'll admit you. But if you have them for 24 hours somewhere else, the whole crisis started going down, and you can have a good look at it. Right. So that's the PGU. I'm going to share something else with you. Especially, you have wonderful 2 big universities, international, in Cairo, you have big population, but also you have Banha, you have Tampa, you have Fayoum, you have Bani Suef, university, you have all these things around you. In Birmingham is in the middle, but then we have around us other cities. Coventry, Birmingham's about, you'll laugh at this, Birmingham is the 2nd biggest city in the UK, and the population is 1.2 million, right? So this is like Shobra, it's a different scale. But we have Birmingham, and then we have another big city, about 500,000, called Coventry, and then we have another cities called Sandwell, Dudley, also. These are all cities around us. And guess what? We are not talking together. We are not linked together. Each city has its own psychiatrist, records, inpatient unit, and we are not coordinating our work together, as if we are in separate countries. So we had a very sad case about a girl called Christine Atkins. This girl went to school on the bus. A psychiatric patient got into the bus, for no reasons, stabbed her to death. So obviously he was psychotic. This patient was in Birmingham, but these patients were coming from Wolverhampton. Wolverhampton is another city, knew a bit about him. Birmingham knew a bit, other people knew a bit. Nobody got the whole picture together. So I became responsible of a national program called Vanguard. You know what's the Vanguard? عارفين الحربة السبير بتاع الحربة, that's called Vanguard. In the army, they send the vanguard into the enemy's troop to push into the enemy's troop, and then everybody follows. أنا عارف دكتورة منى أحسن مني في اللغة العربية. رأس الحرب. Thank you. Thank you. فالفانجارد يعني رأس الحرب. أنا كنت مسؤول عن لغاية دلوقتي بروجرام اسمه Merit Vanguard in 5 cities got together, and what we did, we developed a system to link everybody together. الدكتور عبد الرحمن كان بيسألني عن التكنولوجي. First technology we developed a bed management system, electronic, to link all our beds availability across the 5 cities with the same process and the same criteria. So if I don't have a bed, I can't find a bed in the next city. Also developed shared records. That for the first time, we have electronic shared records between 5 cities. And now we have a 6th city wants to join in. And hopefully we can build the fund. But also, and I know, see the other people in the room here, we developed a website, interactive website to our psychiatric patients, where the patient in mental health crisis goes in his app, and the app knows where the patient is, and the app can tell the patient where he can get psychiatric help at that point of time of the day, whether it's 2 o'clock in the morning or 2 o'clock in the afternoon. But if the patients want to read about bipolar disorder, they can read that. If the patients want to read about suicidal, what should they do? There's advice there. So that's interactive website. So that's the first technology we did. The other one is, believe it or not, we use artificial intelligence. Anybody interested in artificial intelligence? Why are you interested? What do you do?
I'm reading it.
You're reading about it?
About the technology development of and machine learning.
Machine learning. This is what we're doing. Imagine the flight ticket. What decides the price for the flight ticket? I came on Egypt Air. I'm sure everyone on the flight paid different price. What depends on? Artificial intelligence. So the artificial intelligence put who's going to Egypt at what time, the weather, the school holidays, everything, the demand, what happened in the previous years, and they put the price up and down every day. In Tesco or Sainsbury's or supermarket, when they put goods on the shelf, just do you think we put it like anything? The artificial intelligence tells them on Saturday what people want, on the hot weather what people want, on the cold weather what's going to happen, and they stack it in this way. My question to you, can we predict who of our patients going to fall into mental health crisis? Can we? There's multiple factors, it's not just one factor. Can we do that? Actually, we're doing that. So we have, I was the lead for another research project called Testbed, and we use artificial intelligence. We have a company, international company, working with us, developing algorithm for us, which we have developed, to predict who of our patients going to relapse. And the idea is, what I don't want to happen, what are we doing now? We wait for the patient to relapse. And when the patient relapses, we try to do something. In my mind, that is what? That's too late. The quality of life that still was in the family, the kids got hurt, all these kind of things. Imagine I can predict the patient going to relapse and I do something before they relapse. Can we do that? Is that science fiction or true? Okay, so this is what we developed. Not me personally, but working with artificial intelligence company who happen to be owning a lot of networks around the world, and they developed for us the algorithm based on our electronic records for the last 5 years. So what they did, we have 5 years of electronic records, which is about, each year we have 20,000 patients, 5 years are 100,000 patients. Each patient has hundreds of entries, so you can imagine the width of the data, and they do something very interesting. They split the data into 2 parts, randomly. One part is control, and one part is experiment. They developed the algorithm on one part, and they test it on the other part. Can they predict? So they did that. We did a pre-pilot work, see whether our clinicians will use it, and the clinicians said it's actually very good, and about 57% predictability, and that was just the pre-pilot work. And then we did a pilot after we developed the algorithm with 5 community mental health teams, not related to the research project. Each week we send them a list of the patients who are predicted to fall into crisis, and we have set all the parameters why we think this patient is going to fall into crisis, and each one has a weight, and then the clinicians will agree or disagree with it and see how that works. And what they found actually it helps them. They give us, this is the clinicians, gives the information in a nice way. They call the patient. Sometimes they decide not to call the patient. They just report back to us the machine got it absolutely wrong. And this is what, again, who liked this most? I was very worried about something else. If I say the big brother attitude, do you know what I mean? Like, حد بيكسس عليك؟ فكنا خايفين العيانين يشوفوا إن إحنا interfering with their data and spoiling their life and testing what is happening to them. Actually, the patient's engagement was fantastic. We had patients in the project who supported it and loved it and said, please, develop something that we can help us to stop relapsing. So this is our vision. Can we develop? Osama.
So George, the predictive by going through the files, or that sometimes you access the patient directly?
No, you are absolutely spot on, and thank you for this point. It is predicting in our patients, and it goes through their files. This is the stage we are in. What we haven't done is 2 things. This is the future for us. One, we are not predicting the public relapse, but that is the future, using mobile phone network. This is where the whole world is going. I'll tell you something. You and I use iPhone. Your iPhone and the iPhone know about us far more than what we know about ourselves. When we sleep, when we wake up, when we do next, how much you walk. So if somebody was walking every day, 5 miles, and then all of a sudden they are not getting out of the house, maybe they have depression. Somebody does all his text at 9 o'clock in the morning. Now they're surfing the web every night from 1 o'clock in the morning till 5 o'clock in the morning. Maybe they're getting manic. So that is the future, into the other bigger data outside the patients. And the other thing is that mobile phone. Can we use the predictive analytics to link the specific patient and have data from the patient to the phone? That is the future.
I think it's not a very far future.
No,
it's really
no.
happening. I remember كنا في الميتنج في 2014 في الاولد ايج سايكاتري ميتنج وكانوا بيتكلموا على التكنولوجي اللي بريدكت الفولز.
Yes.
Nowadays الابل واتش can
predict your fall.
الفولز وبتبعت دايركتلي للإمرجنسي سيرفيسز ان العيان حصل sudden fall that's not very.
Absolutely. I hope before I retire, we'll see that is happening. But what you need to imagine, psychiatry is changing fast, and the other thing, psychiatry is getting out of its shell and working with every specialty, working with technology,